Welcome to the Docs Who Lift podcast, where we distill and simplify the complexities of a healthy lifestyle, exercise, medicine, and weight loss. We're excited to bring you a podcast that's a prescription for clinical practice, scientific recommendations, and just real life. This is the Docs Who Lift podcast.
Hey, welcome back to the Docs Who Lift podcast. I'm your host, Dr. Spencer Nadolsky. I got my co-host, Dr. Karl and Nadolsky Jr. And we got an awesome guest today, Dr. Jesse Richards, head of obesity medicine down in Oklahoma, Tulsa. Has his own private practice, but also teaches residents and everything like that. So welcome, Dr. Jesse. We're going to be, this is actually both informative for those listening and also going to be a learning experience for me and my brother, because Dr. Jesse has a high prevalence of genetic obesity in his practice. And we were in these Facebook forums all the time hearing about his clinical experience. And I have a feeling that there are cases that I might see, but we're going to kind of learn from him today about his experience with some of these big time genetics. And we're not talking about the polygenetic stuff that we've talked about on our podcast before. We're talking about monogenic and also syndromic obesity,
which we have touched on. So for anybody who needs the background, I think, our Obesity as a Disease podcast and several others where we've talked about the genetics of obesity. We had a whole podcast on that. We definitely touched on these there, but
we're going to dive deeper.
What's fascinating to us is most of these rare genetic obesity disorders are pretty rare, or at least we thought they were.
We thought so.
And we now think, because we actually can look for them and we have some therapy that we're going to talk about for these very specific disorders, that it's probably where it's under-recognized. But you happen to actually be catching a lot for some reason that you're going to talk about. Well, I've been, doing a lot of genetic testing over the past couple of years since we had the availability, and none of my checks they all have like some heterozygous things like PCSK1 deficiency, but haven't had any genetically confirmed Bardet Biedl that we're going to talk about.
Molecularly confirmed.
Yeah. But but what we're interested in and hopefully people out there is, some of the clinical things, because not all genetic testing confirms that.
They're not going to find it.
Man, if you could call this stuff just from a single lab test, life would be so easy.
Yeah.
But unfortunately, clinical gestalt actually still matters because this is one of those weird areas. So
that's important. And I think it's important that we raise awareness because of that, because we think it's probably, or at least some versions of all these things is more common maybe than what we used to think.
This isn't taught on the boards, by the way. What you've
it probably will be now.
So it's tested on boards.
Tested, but what you explain in the forums isn't the way the boards are. We know what these syndromes look like, but go ahead.
Mm-hmm. This is actually how I got into it. I've been really passionate about obesity medicine since med school, and then this is one of the reasons that I really loved listening to one of the first podcasts, was because, I kid you not, my attending in residency, and this was like 2016, accused me of being in the pocket of big GLP-1. We had no idea what the future was going to bring.
That was 2016. We were already we were already knee deep in all the GLP-1s back then.
No, but she was like, well, Victoza is not really any stronger than glipizide. And I was like, okay, slow your roll there. I know. There was a lot of residents dragging attendings, and she was a wonderful attending and got on the bandwagon by the time I graduated residency. I'm not going to knock if Dr. Ray, if you listen to this, please don't get mad at me. But it's staggering to look at the future and see where we're at with incretin-based therapies. Well, so I boarded in during COVID, and I still remember going like, oh crap, I'm internal medicine trained. I don't know this ped stuff. I didn't do an FM residency. I don't know about kids. So I had to go back and memorize all of these genetic syndromes. And just like you guys said, I'm like, okay, this stuff is super rare. I am never going to see it. Well, as you do, FDA announces all of these new drug approvals. And I still remember in December of 2020, I was like, what is going on? Pediatrics got 2 drugs in 1 month. This is unheard of, because they got liraglutide for obesity, and they also got setmelanotide. And I'm like, wow, okay. Well, I remember there's something about this on boards I'm studying for. Well, I'm never going to see it. Well, then a friend of mine works down in South Carolina, and she actually turned me on to the Uncovering Rare panel. And I specifically remember because at that point I was doing primary care, and part of my time was in the obesity medicine clinic as our bariatric and metabolic program is growing. And then it's exploded, like we're up 500% a year. It's just insane, the volume now. But I remember I had this one patient, and you guys you're going to hear this and it's going to click. He comes in, 35 years old, BMI of 65, type 2 diabetes, A1C uncontrolled, bad heart failure, mild kidney disease, metabolic just mess. And I remember, we get him on a GLP, we do full direct medical therapy at him. He got a lot better, and his BMI comes down into the 50s. And then one time he brought his son to the appointment. And I was like, wow, your kid's quite large. And he's like, oh yeah, not real names here. Like, yeah, Timmy, he's going to see the pediatrician about his weight. I'm like, oh, that's great. How's he doing? He goes, oh, he's down 20 pounds. And I was like, oh, wait, what did his weight start at? And he goes, oh, he started at 180 pounds. I'm like, okay, down to 180, 160 in a pediatric patient. That's good. I was like, oh, how old is he? Like 12? And he goes, oh no, he's 6. I was like,
wow.
Oh, okay. And that was the first exposure I had to this kind of multi-generational, something is grossly abnormal. And so then I was sitting there, I'm like, I need to get some kind of testing, because I ended up with half a dozen of these people and, a large primary care panel, and it just was bugging me, but I could never get coverage. And then I found out about the Uncovering Rare program. So we started testing folks in our clinic because we're the only clinic in the state that has medical and surgical interventions for Medicaid. So we're getting all of these super rural, super sick, very high BMI, often very young. It's like just a random Tuesday when I get a patient who's 19 years old and a BMI of 55. So we have this major referral bias. So,
yeah,
we're an academic center, but we're one of the 2 centers in the state that takes. So we get this weird referral bias that comes in. And so I just start testing people. And, the conditions are like pediatric obesity. So I start asking about that in my adult patients. I'm like, hey, do you struggle with weight growing up? What was your weight in high school? And they'll be like, oh yeah, I'm 5'2", and my weight was 290 in high school. And I'm like, not subtle. That's not subtle. All right. Okay. And so then I start getting some of these test results back. And I remember, I think we had like 20 results back. And then I read this press release that was all of a sudden new indication for setmelanotide and Bardet Biedl. And I'm like, oh man, I learned about Bardet Biedl, but I don't have that. Well, then I go look and I'm like, crap, 9 of my patients have at least like one gene, or at a couple, 1 or 2 are compound heterozygotes. And I'm like, okay, well, I read about it, and I remember for boards, you had to memorize it was autosomal recessive. I'm like, okay, well, they only have 1 copy of the gene.
Yeah.
But there's some of these folks who are really sick, they come in 450 pounds, you put them on sema, they drop 100 pounds, they get bariatric surgery, they drop more weight, you put them back on sema. And I had one guy that I remember, he plateaued. And I mean, his life was changed. He was doing radically better. He plateaued on 2 milligrams of sema after a bypass at a comfortable BMI of 43.
Wow. Yeah.
And I was like, hey, he's got one of these genes that's associated with Bardet Biedl. And so I'm like, well, I'm just going to go look up the clinical criteria. And so I go look it up, and I'm like, oh, hey, wait, hypogonadism, chronic kidney disease, neurocognitive issues. Hey, did you ever have any learning deficits? And he's like, yeah, boss, I dropped out of school in 8th grade. I'm like, oh. He's like, and I barely read. I'm like, okay. It's associated with diabetes. And it just check. And now he was not born with 11 fingers and toes. So that's not the pediatric, hallmark. But I was sitting there looking at this guy, and I'm like, I've done everything I can do from a general obesity standpoint, medically wise, because he had contraindications from other meds, and we've done surgery. He's done phenomenal, but there is just something that is not right, And I still remember he was the first patient that I was like, I think you have this.
Mm-hmm.
And so then when I talked to him, and he just like slam dunked all of these major criteria. So the way I'm going to talk about BBS first, and then we'll get back, because I definitely agree. Like the current approval for POMC, PCSK1, and leptin receptor, super, super narrow, patients that are only homozygotes, and coverage is very, very limited by and large. I think I have like 1 or 2 folks on for that. But BBS is one of the ones that it's more common. According to the initial estimates, there's around 2,000 to 5,000 people in the United States that may have it. And we know that based off of the lack of availability for genetic testing, that this is probably underdiagnosed. It's like, for a long time, we didn't have a treatment, and the testing wasn't affordable or covered by insurance. And so it didn't really matter clinically if you made the diagnosis, other than like, you should probably be sending them to a specialist to make sure the end organ manifestations aren't progressing. And so unless someone has an extremely severe case and ends up at like CHOP at the age of 5 with like 5 organ problems, a lot of these folks just kind of float through especially the rural community.
Well, and because that's like you said, so the the term for that, but everyone's so different. Like there's just a lot of what we call heterogeneity amongst the clinical presentation. Some people like have the definitive, like you said, the presentation, they have those things. And some people it's like real vague, other than when we start thinking about these things, like you said, when you do a real weight history and stuff.
Well, Jesse sent us the screening paper, which you'll get into, about like some may have polydactyly, which is extra digits,
right? Which is pretty obvious.
Sometimes they have smaller digits, shorter digits, right? Or syndactyly, or they're fused together.
So it's really amazing, because you would think that people would know if they had 11 fingers or toes, but actually that's certain. Like if it's just vestigial, like because you did newborn nursery at some point. You tie off the little
you tie it off,
or the surgeon comes in and is like, there's no bones, we'll just take it off in clinic in a few.
So for people who are listening to this, tell them what that means.
Tell them all these different terms.
Okay. So I'm going to go through it. Okay. So the hallmark symptom, then the one that you learn for obesity medicine boards, is the postaxial polydactyly, which is an 11th finger or toe. Usually on the lateral aspect, although it can be anywhere. And I actually do not have a patient right now with clinical BBS in my clinic that has 11 fingers or toes. Now, I'm going to caveat that. I have a lot of their kids that do, and a lot of their parents that do. And I think we're up to like a dozen of their cousins that do. But my patient specifically did not have that issue. So Bardet Biedl Syndrome is a genetic ciliopathy. So anybody that's listening, when you think about ciliopathy, you think about like weird renal disease or other stuff. And the major issue is that it affects cellular migration in utero. And so you end up with all of these really mild, odd malformations that may not actually like affect overall function that much, but they are abnormal. So you're absolutely right. The most severe version of the digits is the postaxial polydactyly, but much more common than that is like webbed fingers, which usually gets surgically corrected at 6 months, webbed toes, which is really considered cosmetic, so it's not usually addressed, and I see that pretty consistently. Or most commonly, brachydactyly, which can be shortening of all of the digits, like just some selective digits, most commonly the 5th digit. And when you see these folks, like you walk in, you shake your hand, and then you just like look down, and because like BBS and a lot of these genetic syndromes associated with like abnormal height, usually short, but can be tall as well, especially MC4R, traditionally very tall patients. but you just, like you got to shake their hand and you look and the fingers are just stubby compared to what you would expect based off the palm size. And then they'll like walk in flip flops and sandals because it's warm outside and they have webbed toes. Same things can present there. So, okay, so that's the fingers. Cognitive impairment is another thing that we see very commonly. So learning disabilities are one of the major criteria. Overall cognitive impairment, developmental delay. These are things that are a little bit harder to suss out in an adult, especially older patients. If I have a teenager come in, I'm like, hey, were you on an IEP in school? Did you need help? Learning? Do you have dyslexia? Do you have dyscalculia? I see those a ton.
One thing I was reading, I don't want to interrupt you, but they talked about the visual differences, and that some of those visual issues may have actually manifested like people thought they were cognitively bad just because they couldn't see.
Yeah. So I actually, okay, full disclosure, I kind of do a magic trick because when I walk in and the patient's wearing glasses, I'll just ask, I go like, when between the age of 5 and 15, you just start wearing glasses? And they look at me like I'm like a voodoo person. And they're like about 7 to 9, because it's usually they get caught around that 3rd grade, because that's when they're doing all the pediatric vision testing for the milestones. And then school is checking their vision. And they just usually start to get blurry vision because it can manifest as astigmatism, farsightedness, nearsightedness, or reading difficulties. And you're right, that can mimic cognitive impairment. So the actual main long-term degeneration is a retinopathy. Retinitis pigmentosum or rod cone dystrophy is the kind of syndromic one. The major symptom from that is mild progressive vision loss, which can mimic age-related stuff, but it's mainly a low light vision loss. So like in a normal, well-lighted room, outdoors during the day, people see fine. Maybe they need their glasses for whatever their minor correction is, but they do fine. But then when you ask them, well, how's your night vision? And they'll be like, oh, I do okay. And then you're like, okay, can you drive at night? And they're like, oh no, I haven't driven at night in 10 years. Because their rods are malfunctioning. And anytime their rods are, because they're weakened, are exposed to a bright light, it takes them minutes to reset. Now, this is one of those things it's a retina specialist diagnosis. So it is one of the ones that to really nail it down is difficult. I'm fortunate that we have 2 retina clinics, 2 blocks from my clinic. And I have a lot of folks that are already following to get vision checked. But that severe progressive loss of night vision is the most common thing. And actually I've had a couple of people that walk in, I'm like, do you have any vision issues? And they're like, oh yeah, I follow with retina down the street for retinitis pigmentosa. I was diagnosed 15 years ago. And I'm like, thanks for walking in with the diagnostic criteria. That was really convenient of you.
But what about color blindness though, too? Potentially color blindness? Potentially
color blindness. This is more of an issue in homozygotes. I don't see it as much in heterozygotes.
Can you explain it? I know people are probably you're throwing out terms there that are from medical school. Heterozygotes versus homozygote.
Sure.
Could you?
For sure. Okay. So flashback to Mendelian genetics. We have a number of genetic conditions in obesity that are autosomal dominant, meaning if you have one abnormal copy, the pathway is broken, it's not functioning properly. Bardet Biedl is considered to be a autosomal recessive function, which is if you have one that works properly and one that doesn't work, the one that works properly is still going to ensure signaling. Well, this was based off a lot of family studies that were done in the 90s by Beals and Forsyth and a number of other genetics-based investigators in pediatric populations that were predominantly Caucasian back before the Human Genome Project was done. And I've read a number of those papers, and the stuff that they were able to go in and take these crazy genetic histories and then work out and figure out where the genes were. And this other stuff was amazing. But when you look at the technology they were working with compared to the fact that I can literally swab a patient's cheek and 72 hours to 10 business days later have a comprehensive report back in my clinic.
The future is now.
The future really is now. And so we know that ciliopathies really have more of a variable penetrance. And so there is this huge spectrum, because even back off the original family studies, they had patients that were homozygous pathogenic variants that did not present with the disease. Like you'd have two siblings, two pathogenic variants, the other one, two pathogenic variants, one crippled with every end organ manifestation, the other one maybe gets 1 out of 6.
So explain the penetrance. You just explained it, but like
that's kind of what we were talking about earlier,
yes.
how not everyone gets the features, et cetera.
With variable penetrance, the genetics is the driver, but it's how your body manifests the results.
Yeah,
exactly. Your phenotype, it's a variable phenotype, even with the same genetics. And we have this in a lot of our like neurologic developmental diseases as well. And so you really can see every single one of these like main criteria. I see a whole spectrum of disease. Okay, so we touched on vision.
My brother has 100% penetrance for a Neanderthal.
Man, I was expecting a myostatin comment 5 minutes ago.
No. Okay. Someone's been listening.
I was going to make a joke about the polydactyly and what about how's my brother? He's got a third leg though, so I don't know. I was going to make a joke. About that, but you're in such a good groove, so I'll make it now.
And I just got
for the 40th, actually 63rd. I think this is 63rd.
So it's okay. I can't compete with those. I'm just gonna get some black market bimagrumab in a couple years.
There you go.
You'll be fine.
Well, so with the BBS though, going back to, so we're talking about the genetics of Bardet Biedl syndrome. The other thing about it that I think it's a little confusing to a lot of like clinicians, and certainly I'm sure would be confusing to people out there, is it's not like it's just one gene either.
Yeah.
There's all sorts of different associated genes, and even when we do the testing, and this is where maybe my questions from a more clinical perspective come into play, are we don't test for all of them. So there are patients who maybe meet the criteria who don't test positive because we don't even know all the genes. And there are some more advanced ways to check even deeper, but that's why these clinical things that you're talking about are important, because so for people listening out there, if you or family members or friends, right, have some of these features, they should not be ignored. It's just that it's kind of a new science-ish.
Yeah.
And we happen to have therapy now. And so that's kind of what we're getting at.
And you're absolutely right, Casey. And like I said, this is an area where it was a kind of a learned helplessness before. And now that we have a therapy, we're going back to say like, hey, we should be really carefully evaluating these folks. So, okay, that vision, neurocognitive developmental,
the fingers and toes, and the kidney stuff.
Okay, kidneys. That just like with the others, there's a whole spectrum of kidney disease. In patients that present really young or really severe, they literally will be born with one atrophic kidney that is just a ball of cysts. And I have those. In my.
Are those caught early? Not often, unless it incidentally.
So the answer is they usually have one functional kidney, and so unless something else triggers. Most common thing I actually see that triggers medical intervention is recurrent urinary tract infection.
Okay.
Because this is really strongly associated with not just kidney, but anything that's kidney. If you're thinking about cellular migration, and flashback to peds endocrinology, I talk about each of those sections of cells and the reproductive and the genitourinary tract fusing. There's also a very high rate of ureteral abnormalities, and I see a lot of vesicular. VUR. I still can't say that word.
Reflux. Ureteral reflux.
Yes, a lot of ureteral reflux to the point where I think I probably have 5 or 6 patients that had to undergo pediatric urologic stenting at the age of 3 to 5 because of how bad it was. And I have others where they were like, usually if they're lower socioeconomic status and don't have peds urology around, they're like, oh yeah, I just got 25 urinary tract infections between the age of 2 and 6. And I'm like,
you're like, that's not normal.
I was like, did anyone ever just tell you that's not normal? And they're like, well, my mom got it too. And the doctor just said our family was prone to that. And I'm like, that's not factually incorrect, but wow. Okay. So, a lot of reflux, bladder abnormalities. I've seen duplicate ureteral systems. I've seen functionally normal, but it's kidneys that were anatomically abnormal because they never actually migrated and fused together. So it gets this really external lumpy. So it's 3 completely separate lobes and never fused. And all of these are just relatively benign variants. You also can see a mild but progressive loss of kidney function. Like a lot of these patients that we see that are younger that have like unexplained proteinuria with obesity and all of a sudden there's other metabolic dysfunctions, it just gets chalked up to, oh, it was hypertension, or it was the prediabetes or some other metabolic issue. And it turns out that there's probably actually this like genetic component that can drive that. So on these folks, really the easiest way this one's actually fairly easy to screen for, because you can just check, do they have a microalbumin? Do they have a normal kidney function? Do they, you can get a anatomy ultrasound. That's just a retroperitoneal ultrasound. That's completely non-invasive. It's pretty easy.
And I would suspect that some of these are almost incidentally found with imaging, maybe.
Mm-hmm. Yeah, that seems.
I have folks that it's completely incidental. They'll be like, oh yeah, they said I had like 17 cysts in this one kidney, but my function's fine. So they said, don't worry about it. And I'm like, yep, because this is not the polycystic, like, hundreds of cysts. This is like a number of cysts, or like it's all a spectrum. So then overlapping, because again, that's adjacent, but not the same, because it's a separate criteria. There is a hypogonadism component that's involved in this. Traditionally, this is specifically associated with males. It is not a like 100% infertility. So it's not like, there's something anatomically missing, but it's associated.
And it's a primary, meaning testicular failure. Do you know? I don't remember.
The answer is
I think
the answer is it depends. I see a lot of what looks like either primary, like hypogonadism, testicular failure, or also potentially some hypothalamic. I am not an endo, so like I will do the workup to diagnose if I have men that are coming in with symptoms or that we're screening for. And again, you guys talked with Alex, and so like I see actually a number of folks that have like completely functional eugonadal, pseudo hypogonadism and obesity that don't really fit. But then I also see patients where it's like, well, your total testosterone was 52 and your free was 3. That's not that difficult to make the diagnosis.
So for those out there, we also have an episode on do you have low testosterone, where we talk about primary, which means it's your testicles that have failed, versus central or secondary, where it means there's a problem up in your hypothalamus pituitary area, which can range from damage to tumors to genetic causes, by the way. And that's where we get into some of these things.
Well, okay, pathophysiology, hyperphagia, meaning
well, so that's the feature we haven't gotten to, which is the key of what we're talking about.
That is the elephant in the room. Almost there.
When we're doing a weight history, what we all do, and what we want patients and those out there to think about are, when people were born, what then happened? Was there excessive, hunger, lack of satiety, what we call insatiable hunger as little kids, and significant obesity, early onset obesity. And so that's a real key thing that I think most of us do, that we need to raise awareness of for sure amongst patients and, primary care docs and everyone out there too.
Yeah, you hit the nail on the head. And this is one of those things where history really helps guide. I mean, now, hyperphagia is one of the cardinal symptoms. It is possible to have all of the other manifestations and have BBS syndromes without it, but it is the major one that we most commonly see. And it's the one that setmelanotide like most directly normalizes. And so that's one of the ones that we really hone in on. So I agree. Weight history. And so I only deal with adults. If I can get pediatric records, that's great. But if I can't, really, I start with where they're at and then kind of, work back. So say they're coming in 35 or 40 and go, hey, where was your weight when you were 16 to 18 years old? Because not all these people did high school. Because I asked high school and they're like, well, I didn't do high school. I'm like, okay, rephrase. And then I'll get an answer. And then because central adiposity is actually one of those like big overlaps with the obesity diagnosis as a core feature of this disease, I will actually follow that up with a question specifically asking about like body morphology when they were younger. And I go, okay, if you're female, like, well, what size jeans were you in high school? And they'll be like, oh, I was 16 to 18. women's at the age of 13. And I'm like, that is a lot of central adiposity. Or for guys, because guys don't keep track of pants the same way, let's be honest.
No.
I'll go.
Other than, there was that episode of Seinfeld where he changed the size, and then his girlfriend dumped him because she thought that was offensive.
Ridiculous.
So then for guys, I'll ask like, what size t-shirt are you in? Because that gets the whole like trunkle gut chest obesity, and they'll be like, oh, I was in like a 3XL in 8th grade, and I'm like, there it is.
But their birth weight was normal. So
the birth weight's normally normal, and so then working back from there, when I hear something like that, I go, okay, obviously you had obesity going on in middle to high school. And then I literally, the easiest question to just ask them, because people remember the bias. I go, how old were you when you noticed you were bigger than other kids? And they will instantly tell you, oh, it was first grade, kindergarten.
Yep.
I literally don't ever remember being the same size as other kids from age 4, my first memories. And I'm like, that's terrible. I'm so sorry. Then
in my practice, that those are the ones that get tested kind of no matter what, not necessarily just for Bardet Biedl. When we talk about genetic testing for, early onset severe genetic syndromic obesities, those are kind of the keys.
Mm-hmm.
And I just want to say this because this was interesting. Were you at Obesity Week this last year?
I was.
Jesse?
Yeah.
And Spencer missed this lecture. So, we got there. We just went for Spencer's talk on the debate on exercise stuff. But I got there a little bit early, and I got to see a really nice talk by Faruqi, who's the global leader in obesity genetics.
Mm-hmm.
And she and others, they were talking about how, we've learned so much these days, and how once upon a time, and we all think, we probably all know this, but once upon a time, and probably still, little bitty kids who have significant obesity are being referred to, what do you call it? Child Protective Services.
Yep.
Because it's almost considered child abuse, but it's not. How often do you think this has happened? But it's not the parents' fault, because their children have some sort of strong genetic driver of hyperphagia, and they can't stop eating. And yet, you know what I mean? And how sad is that we've probably missed some of these genetic causes all these years. And it's maybe potentially ruined lives, family lives. I mean, maybe I hadn't really thought about that, and it broke my heart. I was like, oh my God.
Yeah. And this is one of those things, again, I'm not peds, but setmelanotide in these either genetic syndrome or in the rare homozygous monogenic obesity is actually approved down to age 6. And so this is one of those things where I think early identification, or in my case, late identification of a parent who then can, once they realize that they have something going on, look over at their kid and go, they're struggling with the same thing I am, and get them help early.
Yeah.
It can, I think, be life-changing.
What is it about BBS that affects hyperphagia? Because, we got POMC. It's clearly, that's one of the pathways we always talk about. We talk about leptin receptors.
So we may want to review the whole pathway a second. You know what I mean? Just quickly, I don't know if you want to do that, you want us to do it. And because we've done it for the audience before, the whole, the energy balance system of our brain controlling our weight and our appetite and our metabolism. Because it's in that POMC neuron, the hypothalamus, that we're going to talk about.
So for POMC, which is the most distal step in the melanocortin-4 pathway, right before, because it releases the alpha MSH to go agonize on MC4R, which MC4R agonism is the mechanism of action of setmelanotide. So it skips the whole process and hits the final step. So POMC was the first one that was studied, because they said, we have a drug that hits here. Let's look at the people that the previous step is knocked out. Then they went back up the pathway. They looked at PCSK1 because it conducts the signal. Then they looked at leptin receptor, specifically for patients that have genetic mutations in leptin receptor, because they go, if you don't have the receptor, you can't receive peripheral to central leptin signaling. Makes sense. Bardet Biedl is the step after that, because again, we said that this is part of ciliopathy. Well, cilia are involved in a lot more than just like beautiful images of cells on a plate wiggling around. They're actually involved in intracellular and extracellular transport, which is very important when you're trying to conduct afferent to efferent signals through neurons.
I mean, so for the people listening out there, the basic pathway that we're talking about is your fat cells make leptin, which is, a very famous hormone that was discovered, several years ago. That's very important for signaling to the brain about our current energy balance situation. So leptin's supposed to go up to the hypothalamus, where we have these, what we call POMC, that's what we're going to call them for now, neurons. And then it signals those. And then it sends a hormone called alpha melanocyte stimulating hormone up to a second order neuron called the melanocortin 4 receptor. And that's what improves or, works on appetite, satiety, et cetera, and also metabolism.
Energy expenditure, yeah.
So, and so that whole circuit is critical for our whole appetite, metabolism balance and our adipose centers. But that POMC neuron, where the leptin goes and tells it to say, hey, we have enough fat tissue or we've eaten enough or whatever, there's all these different other little things in there. There are a few that are very specific genetic disorders that are rare that, maybe we'll do another episode on that. But then there's this, what we're talking about is this Bardet Biedl, and that's what you're talking about, the cilia, and it just doesn't work. Basically so
BBS hits before that system. Okay, so you did send us a paper on a case report of a GLP-1 agonist. So GLP-1 agonists, there are receptors in the hypothalamus above that. So it should hypothetically work, right?
So the answer to that is yes, it's great to treat hyperphagia in some people.
But it doesn't.
Because just like you have a spectrum of all of those end organ manifestations, there's a spectrum of hyperphagia. Because I have folks that come in and literally the question I ask is, do you feel full? And the answer is either yes, at which point I'm like, oh, that's great. That's very reassuring. No. Okay, that's really easy. Or I get a blank deer in the headlights look because they literally don't understand what that means.
Right. They've never been satiated. They've never been satisfied or satisful in their life. Or like Dad would say, Harry Hachibu.
80%.
So okay. Now, that being said, GLPs, and then obviously topiramate. I don't know actually if this come up with you guys. Like, there's actually interesting evidence that topiramate through the non-selective carbonic anhydrase inhibition can upregulate endogenous GLP-1 production in response to nutrients, and so that's one of the really old upstream mechanisms for increased craving reduction with topiramate. That can help blunt some of this, and I have some people that do absolutely phenomenal on sema. Or especially tirzepatide. But it does not work for everyone. And it seems to depend on how severe the knockout is. And then obviously, if folks have one genetic thing that's wrong, that doesn't preclude them from having other genetics that are wrong. Like I think the average in our clinic, we've tested probably like 450 patients on the Uncovering Rare panel with an 80% positivity rate is like 2 points.
That's extremely high.
Well, and you're going to have to fill everyone in on that part of it later, because but let's kind of conclude this pathophysiology and why we're talking about this medicine called setmelanotide.
The answer is it depends on how bad the breakdown in MC4R pathway is. If they have residual signaling, so they can get full, they just get hungry again really soon. GLPs augment the heck out of that. Works great. But if they just don't ever feel full, I nicknamed it like GLP-1 rebound, because they will eat, they will actually experience a sense of fullness, maybe for the first time in their life, and then 30 minutes later, they're hungry again. And they might still lose weight, because compared to never feeling full, being full for 30 minutes is really just a reprieve for them. But then they get hungry like 30 minutes to an hour later. And I'm sure you guys have had dozens of patients just like I do, that they're like, yeah, I don't get full for a week on semaglutide.
Okay. So for anybody listening, the setmelanotide, it actually skips a lot of this pathway and gets right at the source, right at this thing called the MC4 receptor. So you don't even have to go down below at the POMC.
Right. Where all those other medications we've talked a lot about essentially work up in different receptors of that POMC neuron that really starts the cascade. So GLP-1 receptor agonists, phentermine, topiramate, naltrexone, bupropion, essentially, for all intents and purposes.
Here's a good question then why don't we give setmelanotide? Let's skip GLP-1s. Let's give setmelanotide to everybody for just.
So we haven't even talked about the medicine yet that helps skip this, and that's a very good
I feel
question.
like we've covered most of the syndromic stuff. Like we can
Yeah, we have. I think everybody's got the gist.
So it would probably work, maybe ish. Setmelanotide. I don't know about you. I deal with a lot of Medicaid patients. Maybe you guys have patients, but it's a cool.
I have a lot of Medicaid. Yeah.
Okay. Maybe Spencer has some patients that could afford it. It's a cool $30,000 a month.
30,000.
Yeah, maybe Spencer could afford
it. It literally makes Ozempic look like phentermine cheap because it's a genetic replacement therapy. It's actually been reclassified by the FDA as a genetic replacement therapy because of the missing protein signaling. So what it does is it really, if they have hyperphagia, it just normalizes it, and it's amazing because these people come in and I have just like example after example of. Come in, 8 dietitian visits, see me 5 times, get on 5 of the traditional, old school AOMs, or maybe even on an early GLP if we can swing coverage, gain 20 pounds in a year. And you're like, and the surgeon's like, I don't want to operate if they're consistently in an upward trend because I'm worried that if this isn't controlled, it's going to affect post-op stuff. You put them on Imcivree, and I had a patient that she was gaining weight 5 pounds a month on phentermine 15 and topiramate 50, and put her on setmelanotide, and she came back 2 weeks later and had dropped 14 pounds.
Wow.
And she literally cried to my nurse because she was like, I didn't know that this was what feeling full was like.
Mm-hmm.
Yeah. Which is what we hear a lot just in general, what we call polygenic obesity.
Yeah.
From a lot of patients who have just struggled their whole lives, just in general, when we get them on semaglutide, tirzepatide, et cetera. But the patients we're talking about today and in those other rare genetic disorders, they don't feel that way on those medications. They feel it on this one that skips over the dysfunction.
So in common obesity, though, it's not a very set dysfunction, like specifically in one spot in the brain. So I have a feeling that you obviously setmelanotide is a very specific receptor for very specific diseases, whereas common obesity, there's probably other dysregulation in the brain that the GLP-1s likely help with, the reward system and other components. So I think that's kind of what I was getting at. And obviously, I think there's also side effects from setmelanotide.
There are different side effects, and it's costly.
When you look at the side effect profile on topiramate, it's kind of horrifying. But setmelanotide, absolutely. So when you compare it to that, like it's not really that much worse than some other stuff we use, but there are definitely side effects. The number one is hyperpigmentation, and this will freak patients out if they are not properly educated on it. Basically,
so explain why, because it'll make sense if people look into the hypothalamus and these different hormones.
The receptor that we're talking about that's broken, that downstream from POMC, is a melanocortin 4 receptor. Now, setmelanotide is a relatively specific melanocortin 4, but it also hits melanocortin 1, which is what causes your skin to release melanin or pigment. So
your melanocytes
get stimulated by this. Now, there is a theoretical risk of concern. There's never been any cancer signal in anything of these trials that have been going on for 10 years. They're monitoring for long term. I just wanted to put that disclaimer out there. It's not the same as getting shot up with UV rays. But there is a significant increase in pigmentation. It depends on the baseline level of melanin production. So I have a lot of patients that don't get outdoors and are very, very, very pale. And so for them, their skin turns 2 shades darker, and it's still well within the normal range. But I have a lot of folks, then there's variability in this response, just like there's variability in everything else. I had someone complaining because she did not have any response from a skin perspective. And then I had a patient that came back and her skin was 5 shades darker, and she ended up deciding to discontinue the medication. This also seems to make folks, because of that baseline stimulation, more sensitive to sun exposure. I have a lot of folks that come in and it's basically like a farmer's tan on steroids. And so I tell everybody to make sure you wear a sunscreen. That's not officially on the label, but I've seen it enough at this point that we recommend it.
Have you guys heard of Vyleesi? Bremelanotide?
So, yes, actually I have. And Vyleesi has 2 phase 1A human prospective trials of once a day or twice a day dosing. The molecule is called bremelanotide. where they actually showed generalized weight loss and a reduction of, I think it was about 490 calories a day in a metabolic ward over a 2-week setting.
That's pretty amazing. So, Casey, you know what that is? You might see sexual dysfunction. Well, they're calling it female Viagra.
Yeah, but that one hasn't been. Is that the one that was?
It's made
just
for sexual dysfunction. MC1 and MC4 non-specific receptor agonists.
Yeah. No, I think I shared. Was it just approved?
Pretty relatively.
It was approved in
2020 for sexual dysfunction. Because I shared it because I was like, this is something that people should know about, but I have not. Used it or engaged in it yet.
I stumbled across that drug because I was trying to learn more about setmelanotide, and I Googled MC4R brain MRI, and a study on bremelanotide came up, and I went, what the heck is bremelanotide? I've never heard of this drug. Well, it turns out my wife's OB-GYN in the same academic group. Every time I walk over to her, I walk past a poster for that drug, and I just never knew. And if you go on Lexicomp and you look at the side effect profile for the two,
it's weight loss.
They're identical. Every single side effect
that's what I was
exactly the same.
Because I was just learning about it. I was like, what? This is like the same thing, but it's women can get it for much cheaper. I assume it's not as effective necessarily. But
it's basically $100 cash for a pack of 4 auto injectors. So like 4 doses of the medication or 4 days of the medication is $100.
Okay. That's interesting.
And
we'll see what happens there.
I know there's definitely a lot of, I'm sure there's probably some off-label use. I may be talking to them about possible.
I wonder how much trouble I'm going to get in if I make any specific comments about it.
Yeah, I wouldn't make any comments.
Nope. I will say, though, that
I already got trouble.
You just got fired.
There does seem to be some weight loss related to bremelanotide. And so there may be a general weight loss as well. But in the context of the monogenic and syndromic obesity who have a specific dysfunction in the MC4R pathway, it's a radical improvement.
Do you see libido improvements with setmelanotide? Because that's so the women, I see it on TikTok. They like rave. They're like, I took the Vyleesi, and they don't say specifics. They just go, it works, and I'm just like,
actually, one of the hyperpigmentation is the most common. Actually, I counsel every single patient on increased libido. Technically, this in the IMCIVRE trial, there were 4 teenage boys between the age of 14 and 21 who experienced 1 spontaneous erection over a 12-week period. Now, that being said, in clinical real-world use, I have a lot of patients that come back and who tend to be about 35 to 50-year-old females who go, I might be in the mood more, but I think it's just because I feel better and everything is overall going better. So I would say I definitely have noticed some increased libido, nothing that would be uncomfortable or concerning from a tolerance or discontinuation perspective. Does that make sense?
I guess I'd have to talk to somebody to understand how the MC1 and MC4 regulate sexual function libido in the first place for women specifically. I haven't looked much into it.
Well, the last thing we need is for you to take an injection.
All right. Let's see.
I see you just did that. I see you just ordered some and just injected it. It just came on one of those.
Amazon, the drone came.
Amazon the drone came and just injected it right into Spencer.
Just like, get me off this podcast.
The other big thing that's really interesting with this in the actual clinical treatment is that we see these crazy body composition changes even outside of scale changes. I had a patient come in last week. This is anecdotes. I sent you the body composition changes in leptin receptor, which actually showed like lean mass was stable while weight was going down pretty significantly over, I think it was a 12 to 24 month period, which is very, very reassuring because one of the things we always worry about with AOMs is decreased lean mass. And so I had a patient come in, had been on medication, I think 10 weeks, and dropped from a gene size 18 to 14 with no physical activity and only lost 2 pounds. Which is, and when you think about it, this genetic dysfunction is causing it's the signaling impairment, and they are predisposed to severe central adiposity. So I don't think it's necessarily that the drug just like strips adipose off. I think it helps renormalize what their body would have been holding at baseline.
Yeah, there's a partitioning effect. There
Exactly.
seems to be.
Yeah.
Because why would it be central as opposed to everywhere,
Yeah.
global?
Yeah. And
Central
so-
means, so if anybody listening, partitioning effect is where you would store muscle or fat. And in this case, in BBS, there's for some reason, a central storing of adipose, as opposed to other people, they just have a lot of adipose everywhere, legs, hips, and abdomen and arms. So for some reason in this syndrome, and I don't know, there must be some partition. It must be the ciliary effect of something. I have no idea. I'm not sure. You might know better.
Casey, if you want to weigh in, but like, I think it's one of the things is the downstream effect of leptin is actually modifying the CNS to peripheral adipose sympathetic tone, and is affecting some of that like brown adipose recruitment and like metabolic.
Might be the hypogonadism as well, I suppose, if that's the case, which can have a big effect on it. There's probably a ton of things that could contribute to it.
Right.
So
a lot of different aspects.
Seriously, this has been informative. We're basically up in the hour. We don't usually go this long. It's like I personally want to figure this out because I do all telemedicine, and so I think I'm gonna have to come up with screeners. I'm trying not, we don't want to screen everybody, but I think
if I can tease, we have a submission into TOSS that I'm very hopeful it gets accepted. That gives everyone the standardized screening that we implemented in our clinic to get a 80% positivity rate on uncovered.
That's amazing. And I can't wait. I'm going to wait for that.
I want to specify, when I say 80% positivity, I mean that we came back with an abnormal variant of uncertain, likely pathogenic, and that's heterozygotes or homozygotes. So that's not just people that come back with, pathogenic genes. That's more in like 5% of patients.
That reminds me, I wanted to ask you about your specific geography and perhaps that selection bias, because we test a lot of people based upon that history, right? It's very important that if people out there have the early onset obesity, any of these features, or any, just anything that seems off, especially from childhood, that the pediatricians and the adult doctors like us, that we're aware of it, so we can consider this genetic testing. So we test a lot, but we haven't gotten that much. You definitely have a higher positivity rate. So tell people about that and why it's not just going to be everywhere.
So I want to say that while we have a standardized workflow, like literally my nurse walked in yesterday and she was like, positive screen, here's her major and minor criteria, but I haven't announced any nurse. We live kind of in the buckle of the obesity belt. I'm in eastern Oklahoma, which is not that far from western Arkansas, Louisiana, western Mississippi. And we have a very, very large, very rural, high consanguinity, which just means basically you're part of a relatively small gene pool because you were separated from other folks. We have a very large Native American population. We actually work with several of the tribes pretty closely. And there's also like a lot of like just segregated communities, Amish, Mennonite, things like that have been relatively closed off. And when you think about it, wherever a lot of these original genes actually came up, well, actually one of the original BBS studies was in a founder effect in an Amish population. And some of the other monogenic obesity stuff was in the Ashkenazi Jewish population, because they have a higher rate of this as well. And you see it, all over. Anytime that there's like an island, anytime that there is just a closed off segment where people don't have as much intermingling, these genes can propagate down and get carried forward. So with that in our specific referral bias, I think that really increases the rate, like the baseline of our clinic. But I do think that just by catching these historical things, which really sounds like you guys are already pretty much clued into, that can help guide who is an appropriate patient for screening testing.
I love it. You better let us know when that's
awesome.
out, because I am going to incorporate this into telemedicine or telemedicine.
Absolutely.
Yeah. And for patients, again, I just want to reiterate, for people out there listening, if you or your family or friends have some history that suggests that something was off from an early age, extreme hunger, insatiable hunger, other abnormalities, from mental issues, learning deficits to, extra fingers or whatever, to also primary care docs. I want to hopefully work with my pediatricians in the Holland Hospital system and all the family docs and make sure that there's an awareness. I think the first step is we got to raise awareness, and because it's important that we dig deeper and help these people and not just let them fall through the cracks.
Yeah. Thank you, Jesse, for coming on.
Absolutely. Guys, this has been absolutely a blast. If I can show one thing before I leave.
Yeah.
Yes, please.
Okay. I don't know, who made that decision, but if you want to hear somebody ramble about this for an hour with a bunch of PowerPoint slides and very complicated feedback diagrams, I will be doing that at one of the keynote lectures at TOS this fall.
Nice.
Oh, really? You're going to be at Dallas?
Yeah.
Yeah, I don't know if I'll be able to. I might
You
be able
better
to make
come
it for the weekend or something.
Come on, you want to.
Let's just go.
I got to. Well, I try. I got to give a talk the weekend before in Maryland or something. And anyways, yeah, we'll see.
Awesome.
Cool.
I'm part of the steering committee. I think I got you on to speak probably.
That's great.
I helped develop the program.
That's great. Thank you so much for coming on. We'll probably have you on again. If anybody, again, share this, give us a good review on wherever you're listening to this. And if you're in Oklahoma, you want an obesity doctor, Dr. Jesse Richards is the guy.
My wait list is about to explode.
All right. Yeah, don't go. Okay, just come to us at Sequence, I guess. Whatever. All right. Unless you have genetic stuff. All right. Anyway, thanks for listening.
This podcast is for entertainment and education and information purposes only. Remember, the physicians on this podcast are not your physician. It should not be considered professional or personalized medical advice. It should not be used to replace speaking with your physician or medical professional to discuss your specific health concerns. The topics discussed should not be used solely to diagnose or treat any condition. As a result, we are not responsible for any unwanted medical outcomes. The views and opinions discussed are of those of the host only and do not represent those of any other entities.